Hey there, welcome to the next in the clinical psych section. Today's lecture is on therapy. So I wanted to start by thinking about the actual day-to-day experience of going to and being at therapy. Uh, the first question really being, does therapy work? Throw an even in there. Does it even work? The first important point to keep in mind here is that clients tend to overestimate the effectiveness of psychotherapy. So what typically happens is people start therapy when they're in some kind of crisis. So because events and states and moods and situations all kind of ebb and flow naturally, the crisis passes and people often attribute that improvement to the therapy that they sought when they were in the midst of it. It's also possible that people who go to therapy might need to deal with a little bit of cognitive dissonance in that they invested time and money into the therapy, so they want to feel that it's been worth it. And clients also generally speak positively of therapists who've been understanding and who've helped them gain a new perspective, but those factors aren't really related to the effectiveness of the therapy. Clients don't tend to have accurate estimates of their therapy's effectiveness. So because they typically enter therapy when extremely unhappy, leave when they are less extremely unhappy, and stay in touch with therapists only if they're satisfied, many clients feel like therapy was a success. And so therapists end up testifying to success as well because they only hear from the people for whom it works. So another factor or feature in all this too is that clinicians become aware of other clinicians' failures when clients seek new therapists for the same problems that they've tried to deal with other folks. So the general kind of question, does therapy work, is not one very well tuned to self-report, in other words, from both clients and clinicians. So what we try to actually do is engage in evidence-based practice, which means that many randomized clinical trials are run to test a type of therapy, and then we engage in a meta-analysis of all of those trials. Same as what you might imagine happens when a new drug is tested or a new vaccine or anything like that. And this evidence-based practice involves really careful clinical decision-making to integrate this best available research with that particular clinician's expertise and the preferences and characteristics and needs of a particular patient. So there's an aspect of this which is very specifically tailored to that clinician and that client. So the clinician has a set of available therapies that have been rigorously evaluated that they can then apply. And so the difference between maybe the paper it's pulled from and the actual application has something to do with the patient's unique situation and the clinician's own skills. It's also true that people who don't undergo therapy often improve, but there is good evidence over many years now suggesting that people undergoing therapy are more likely to improve than people who do not seek therapy. And they improve more quickly and they have a lower risk of relapse. Therapy is most effective, in fact, when the problem is really clear-cut. So think of like a person who has a specific phobia. Nice, easy, clear-cut problem should be a cinch to solve. Just engage in some association, some extinction of that association over a period of time will eventually get you to a higher functioning place, a place where you can go about your daily life. But again, this has to be evidence-based practice. Despite all these differences and the specific application of therapy from one place to another, all therapies do offer at least 3 benefits. First off, they offer the expectation that things can and will get better. And that can be a hugely important starting point for patients. So as long as they commit, things can improve. Another benefit of therapy is that clients will gain a plausible explanation of their symptoms and an alternative way of looking at themselves or responding to their worlds. they get they receive a diagnosis, and that often leaves people feeling relieved. They feel like, I can explain all of these symptoms I'm having now, and that helps as much as the actual recommended future steps in some cases. And then the third benefit is therapeutic alliance. Good therapists are empaths. They're empathic people who try to understand somebody else's experience, who care about their clients, who show their clients that they care about them and are concerned for them. And in many cases, their respectful listening, their reassurance, and their advice can earn trust and respect from clients and can lead toward an emotional bond that researchers call this therapeutic alliance. It's a key aspect of effective therapy. The patient has to feel like the clinician is on their side. So all therapies are offering hope for people who are in a demoralized place. They offer those people a new perspective on themselves and the world, and they offer an empathic, trusting, and caring relationship, no matter what kind of therapy that particular person is doing. A particular therapist's personal beliefs can and will typically influence their therapy. Their values will be infused into their therapy as well. They typically all agree on the importance of encouraging clients to be sensitive and open and engage in personal responsibility, feel and be responsible for their own actions. But they can differ really sharply on things like pursuit of self-gratification, pursuit of self-sacrifice, things like interpersonal commitment. You sometimes will see people try a couple of therapists before they find one whose values on some of these issues align with their own. Those value differences can become particularly important and obvious when a client from one culture or one gender meets a therapist from another. You could imagine a client from a collectivist culture trying to deal with a therapist from an individualist culture encouraging them to think about their own well-being. That would not necessarily be the first goal for that person, right? They would want to think about the well-being of their family and of their community before themselves. So you have to make sure in seeking a therapist that you can find somebody whose values match your own. You can imagine that a woman from a collectivist culture might be doubly uncomfortable if she had a man from an individualist culture as her therapist. So, those issues combined with the fact that the large majority of psychotherapists are Caucasian, especially in the U.S., and that I believe the majority are still men, can kind of start to show why there might be ethnic differences in seeking mental health services, and could explain some of that reluctance to seek help from minority communities. So the takeaway there, of course, is that we need more representation in the world of clinical psychology, but we can't just say that. We have to actually engage in structural change that makes that more possible, which is a larger issue, not to be necessarily dealt with in this lecture, but something that if you want to think or talk about as a student, I'm happy to talk about with you anytime. So to wrap this sort of slide up, in choosing a therapist, you might want to consult with a few. Ask questions about their treatment approach, their personal values, how their personal, maybe you probably shouldn't say what are your personal values, because they will say, well, those don't matter here. But what are their values in treatment? And definitely also ask about their fees and their fee structure, and see whether your needs match with what they can provide. Now, all that said, today I want to talk about the key features of some different types of clinical psychotherapy. So we're primarily going to talk about the first three bullets here: psychoanalysis, humanistic therapy, and cognitive behavioral therapy. We'll get into some of the rest of these later on. I think the behavior therapies are in the next video, and then we'll talk about biomedical therapy later on as well. So psychoanalysis is the oldest type of therapy. It's based on some of the theories of Freudian psychology. The goal of psychoanalysis is to help the patient release repressed feelings from earlier in life and try to gain insight into themselves, how they think, how they react, how they emote. So the goal as the therapist is to try to find the unconscious origins of the person's psychological disorder, to work through the feelings that accompany those origins because they've been repressed, and then for the client to then take responsibility for their own growth and their release of those repressed feelings. So they use techniques like free association, saying anything aloud that comes to mind. They use a technique called resistances. This is the defensive blocking from awareness of anxiety-laden material. So the therapist looks for places where the client doesn't want to talk about a particularly anxiety-laden episode from their past, and then they will interpret that resistance and try to encourage the client to deal with those emotions. And they'll also watch for behaviors like transference. So sometimes a client will transfer a feeling that they've repressed for a long time to the therapist or to someone else in a story. And so you're probably already gathering that the interpretations of these techniques can be pretty subjective. And it also is a time-consuming and costly endeavor in therapy, in that it can last many, many years and many, many hours per year to work through and establish and find, first of all, to find these events, to find the place that your feelings have been repressed, and then to work your way through the emotions. So it's not quite as popular as it once was, and I could continue to dunk on Freud all I want. We have a little bit already in the personality lecture, so head back there if you want to see anything like this. But the modernized version of psychoanalysis is called psychodynamic theory, so you can think of it as just like psychodynamic theories of personality. So in psychodynamic therapy, the therapist seeks to understand the symptoms of the psychological disorder based on the patient's childhood and the relationship between the patient and the therapist. So you can see where some of those same kinds of ideas have come through and stayed part of it. But they focus a lot more on short-term symptom relief than long-term personality change, because it's just not reasonable for some clients to seek therapy for hours over years to try to get past what they're dealing with. Sometimes they train other things like mastery of relationship skills and other sort of short-term type issues as well. So if you're following along with the theories of personality vibe, we're actually going to stick with that. The next type of therapist is a humanistic psychotherapist. So a humanistic therapist will try to help the client gain insight into their fundamental self-worth and value as a human being. So there's a lot of empathy going on here. They see therapy as an effort in discovering a person's potential. They believe that free will enables us to fix our own problems, and so it's the therapist's job to help the client rediscover their natural self-worth, to get them in touch with their own true feelings, desires, and needs. So there's a similarity with psychodynamic work there, getting in touch with your true feelings. But the humanistic therapist will act as a confidant and as a friend. They believe that we lose sight of our potential, that we can sort of get down on ourselves, and that it's the job of the therapist to encourage us to not let others control how we think and how we feel, and use our free will. They emphasize conscious thought, what the person's actually thinking day to day, very similar to psychodynamic theories. But the goal is to be 100% supportive and non-judgmental as a therapist in the conversation. According to humanists and humanist theorists like Carl Rogers, the most effective form of therapy is therefore client-centered, because it is the client who holds the key to their own psychological health and happiness. You'll see kind of the reverse of this in cognitive behavioral theory in just a minute, in which cognitive therapists will criticize or correct irrational thinking rather than be 100% supportive like a humanistic therapist will be. The core qualities then for a therapist are to be genuine. They want to act without phoniness, express true feelings in an open, honest way, be the confidant for their client. They want to show unconditional positive regard. This is that 100% supportive part of the relationship. They don't want to put any conditions of worth on the client. They don't want to put their values on the client at all. They have to be totally accepting and respectful of their patient, their client, at all times, even if the client thinks and acts in a way that seems irrational or inappropriate. Because remember, humanists believe that all people are essentially good. They just need to be placed in an environment that will nurture their innate tendencies toward positive growth. So they, again, encourage empathy at all times. And there's similar critiques to this as there are to humanistic theories of personality. A cognitive therapist or cognitive behavioral therapist approaches therapy from the place that a disorder is a series of conscious and irrational beliefs and negative thoughts. So, for example, in depression, a cognitive therapist would need to know how a depressed person thinks. And you already know this from a previous video. So you know that a depressed person doesn't think productively. They think of themselves as worthless. They think of themselves as unlovable. They think things won't change in the future. That they are drowned by these negative thoughts and beliefs. And so a cognitive therapist would say that thinking in this way clouds your interpretation of a normal event. Your everyday experiences are all negatively filtered. You see everything as a glass half empty and often jump to irrational conclusions. For example, imagine a woman with depression whose husband arrives home late from work. She might immediately become convinced that the husband's having an affair, or vice versa. Imagine a depressed man at home whose wife arrives home from work. Or imagine a depressed student who fails the quiz, seeing the F as confirmation that they're stupid, that they shouldn't be in school in the first place. These are irrational thoughts, right? A couple minutes late does not mean an affair is going on. One bad grade on a quiz has nothing to say about your mind and your capabilities. So a cognitive therapist would say that it's not the direct experience, it's not the failure of the test itself, it's not the late arrival home of the spouse, because these things happen all the time. But in the mind of the depressed person, the issue is the accompaniment of an irrational belief, the belief that then leads to a negative emotional consequence. So it's that interpretation of the event that is the issue. Therefore, a cognitive therapist needs to figure out how to change a person's beliefs. And the approach is generally active confrontation, sometimes aggressive confrontation against those beliefs. So in a particular subtype of cognitive behavioral therapy developed by Albert Ellis, a rational-emotive therapy session would be a situation where the therapist acts like a cross-examiner, kind of. They try to verbally assault the irrational thought processes that the client has, without assaulting verbally the client themselves, of course. They want to point out the irrationality of those processes. They want to say, no, those couple minutes late say nothing about your relationship. That F on that test says nothing about you as a person. It's just one score on one test. The goal being that you can encourage the person to eventually lose the belief and lessen their emotional consequences. Ellis went so far as to define a set of major types of irrational beliefs that are interesting and useful to go through. One is, I must be loved and approved of by every significant person in my life, and if I'm not, it's awful. So any singular instance in which you can judge an interaction with a loved one as anything other than perfect and amazing would send someone in a downward spiral. It's awful when things are not the way I'd like them to be, a kind of control issue. I should be very anxious about events that are uncertain or potentially dangerous. I'm not worthwhile unless I'm thoroughly competent, adequate, and achieving at all times, or at least most of the time, and at least in one major area. I need someone stronger than myself on whom to depend and rely. So the therapist will initially try to pinpoint which of these beliefs characterizes that client's thought processes so that they can work on them accordingly. This is kind of like the ground truth that we're seeking across different clients. The key to these is that they are inflexible. A person needs to believe these things in an absolute way. I must be loved and approved. Look at the language used in these statements. I must be thoroughly competent. It is awful when things aren't the way I'd like them to be. The client believes these things firmly and inflexibly. And so moving them beyond that and encouraging them to remember that any imperfection in the armor of these statements does not lead to some catastrophe. It just leads to the next day. That might not sound great to you, might sound a little intense. A theorist named Aaron Beck takes a more subtle tack, offering that you could lead the client to identify the negative tendencies themselves. So in this kind of cognitive therapy, a therapist acts as a co-investigator. You can become kind of like psychological detectives. Beck even asks clients to record their automatic thoughts in a notebook between sessions, so they sort of feel like they're collecting evidence in their detective case. And that's reflected in the general goal, the general sort of method of this kind of therapy, which is really intensive record keeping. And the idea is that you would write down the event, write down your automatic response as the client, and then try to write a rational response to those thoughts and emotions, like you're a scientist evaluating the data. Sometimes people do that with the therapist at first and then on their own later. So you'll answer like, okay, I had this event happen to me and I had this thought. Is the thought justified by the event? What's the evidence for the conclusion I reached, and what's the evidence against the conclusion I reached? And so again, the idea is that clients eventually discover these patterns and start to be able to work on them themselves. So those are our three major types. I also want to tell you a little bit about group therapy, which can kind of fit into some of these, but basically the idea is that if you sit in a group of people who are having similar problems, that social context can help us discover that similarity, which can be validating. It can help people feel better about their situation. And then the conversation with those other folks in your same situation can give you an idea for new ways to behave based on how they've responded to similar issues. It's also a really good opportunity for honest feedback. It's easier to take feedback from someone in your same situation. And it's also a nice way to have these discussions while avoiding social stigma because, again, everyone in the group is in the same boat. A subtype of group therapy is family therapy. And the assumption there is that by seeing the whole family at once, the therapist can get an idea of the relationships within the family and they can help the family work on how those relationships affect individual psychologies of each of the people. So they try to guide family members toward positive relationships and improved communication, and try to encourage them to become more healthy as a unit, as opposed to thinking just about an individual. Another big advantage of group therapy is that it can help people deal with problems that maybe seem unsolvable. So if people have stigmatized or hard to discuss illnesses, these kinds of groups, support groups, and self-help and group therapy can be hugely helpful. So that finishes this first piece of therapy. We'll talk about some specific therapies for specific disorders in the next video, and then we'll also have a video on some other treatments for psychological disorders outside of these mostly talk-based therapies. See you in those.